Thank you very much, Professor Ahmad. And I really need to appreciate you and your team for able to conduct this continuously. And we have crossed first anniversary, and we are heading towards maybe like second or third year. I myself had the opportunity to present the minimally invasive treatment in BPH last time. But believe me, this is such a very evolving topic, and we have so much of newer energy sources coming in the market. Lot of research happening, good amount of healthy competition among the pharmacy people that derives the quality of the care for men suffering from lower urinary tract symptoms. I will discuss predominantly four energy sources. I mean, we can discuss maybe eight, if not nine energy sources which are evolving as minimally invasive treatments. But there is a small possibility some energy sources may fall apart and may not stand the test of time, as they say. But these four have got good track of good amount of investigations, randomized studies, publications, and also various scientific basis to that, of which three are expected to give a permanent or at least long-term outcome, and one of them is like a temporary prostatic stent. So we will go ahead with Eurolift. So everybody can see the slides, isn't it?
Yes, they're clearly visible. Thank you.
Thank you. So Eurolift of everything is very close to my heart because I'm one of the proctor for Eurolift. I do a lot of workshops, especially in Birmingham Treatment Center. We do workshops almost every second month. People visit from various countries. Not only the surgeons, we also have people like urology nurses or managers who are quite interested in this procedure, and we have trained, and I'm very proud to say, at least 50 to 60 consultants who are doing Eurolift now quite regularly. Apart from workshops in the urology department in Birmingham, I also visit various countries like, for example, India, Singapore, and Middle East countries, and also the European countries like France, where we train the surgeons. Possibly the next stop is Pakistan, Professor, whenever the time and date permits.
Absolutely. It'll be honored to have you anytime of your choice.
Thank you. Thank you very much. So let's go through the basics and some evidence behind this energy source. Eurolift system, how we are going to select the patient and how we need to screen the patients for this, and what are all the components of it, and how are we going to deploy the Eurolift equipment, what is the anesthesia needed, and how we will plan the procedure. This is the outline of my presentation. Urolift is indicated for men suffering from benign prostatic hyperplasia. The minimum age is 50, and there is no real maximum age, but guidelines wise, because of the available of data, they say 80 years may be an ideal one. But I have operated men up to 92. The youngest men we operated were in the region of 43 or 45 years. But ideally, from the evidence point of view, the minimum age is 50. Regarding the size of the prostate, indication wise, there is no real lower limit. We can do up to 100 cc's. I've done few patients marginally above 100, like 105, 104 cc's, as long as the prostatic anatomy is permissible. But if you go by guidelines, the maximum size for the EAU guidelines is 80 cc, and for NICE guidelines is 70 cc. If you have a prostate gland size from 40 cc to say 70 or 80, the outcome is very good. There are only two things which will make the Eurolift outcome excellent. The first thing is appropriate patient selection, and second thing is excellent technique. Technique wise, I will say the learning curve in the region of 15 to 20 patients, and then you can do even the complex Eurolifts like median lobe surgery or 4D technique for the high bladder neck. But selection of patients are very important. Sometimes you may have a patient, say 80-year-old, prostate 100 cc, not very suitable for other procedures. Urolift can be done completely under local anesthesia with just like lignocaine jelly alone. There is no need for even an IV line. There is no need for sedation. There is no need for nitrous. So this is a very attractive procedure for elderly men who are not suitable for, say, regional anesthesia or for general anesthesia. So if we extend the indications and try to do patients with large prostates, obviously the outcome will be a little bit suboptimal. But somebody of 80-year-old who has to lead the rest of the life with a catheter, he may be quite happy to get rid of the catheter. He is not expecting to, like what they say, like pee like a horse. All he wants is a very decent, good quality life without catheter. He don't mind a little bit of poor flow. So this group of patients, we can say we can do extended indications and Urolift has a role to play. And this is our aim. The video shows
invasive
everything.
technology.
So as you can see that the animation shows where the prostate is located, and we are going through the urethra, negotiating the bladder neck or the bulbar urethra or the two main areas we need to concentrate. As you can see from here, it is a normal cystoscope 20 French, which is much smaller than the TURP cystoscope. The Urolift should be positioned appropriately inside the bladder, and as you come out you need to give at least 1.5 centimeter from the bladder neck. Otherwise there is a possibility that the needle may enter the bladder neck and cause implantation into the bladder neck. Any Urolift implanted in the bladder neck area or in continuous touch with the urine in the bladder, we need to remove the implant, because the implants in constant touch with the urine can cause incrustation. While as long as the implants are in the prostatic urethra, they will come in contact with urine say 6 times or 8 times in a day, so they are quite safe. As you are seeing, we need to apply the first pair of the proximal implants, and then as you come back you can schedule or plan the implants giving enough gap, and this bulge in the tissue between the implants will get apoptosed in 12 months time. If you or happen to do a flexible cystoscopy, say for example patient is on follow-up for TCC of the bladder, those patients, when you do a flexible cystoscopy in 12 months time, you can see that this anatomy has become a much more opened up cavity. Obviously, the cavity attained stays easily for 5 to 7 years. We have got evidence for that, and now as we wait longer, we may get more evidences on long-term follow-up. So patients who are on watchful waiting or on long waiting list for TURP, patients on medical therapy but not happy with the medicines, say absence of ejaculation due to tamsulosin or absence of libido due to finasteride, those are all the patients very suitable for Urolift. And when you are taking the patients who are already waiting for Urolift TURP surgery, just make sure that patient's anatomy is conclusive for us. As I said, guidelines wise, AUA guidelines, EAU guidelines and NICE guidelines support the Urolift implementation. This is one of the very important slide. This is the healthy bladder mucosa, as you all aware of, and this is the patient where there are some trabeculations due to the hard working of the bladder against the obstructing prostate, and here the patient obviously developed trabeculations and saculations. This should not happen. This is like equivalence of organ confined malignancy which has got metastasized. As an oncology surgeon, especially Professor Hamad, if you see an organ confined malignancy, whether it's a bladder cancer, prostate cancer or renal cancer, we need to treat the cancer and we need to make the patient cancer free. We fail in our treatment if we allow a neighboring organ getting affected, like for example lungs or distal metastasis because of the cancer. So how can we allow bladder to undergo the impact of the prostate? So this is where the pre-font or upfront treatment comes into play. When you are going to have an upfront treatment protecting the bladder from all the secondary effects, that upfront treatment should be good enough. It should be a simple one, it should have less side effects, and it should be easily deliverable. All these boxes are nicely ticked by the Urolift implants. So patient selection is very important. As I said, we need to make sure that patient's prostate size not crossing 100 cc. And as I said, these are the main three group of patients with which we will select the patients for surgery. And you may be having these patients already in your practice, and please perform IPS score, get the quality of life, make sure they have a symptomatic disease, and the basic parameters are very important in the follow-up also. This is our gold standard lift study. As you can see in the lift study, there is a rapid decrease in the IPS score, which shows good improvement of symptoms within the first month. And the blue line is my cohort of patients, and they also had very good improvement quite quickly. And the results are quite durable for very long term. Lift study now has this graph shows 5 years, but now we have the 7-year data. We have real world study where the patients were included not from any standard studies, and BPH 6 studies and multi-center studies and Australian studies. All the studies shows good improvement in quality of life and good improvement in the IPS score. In long run, they have done the dog or canine experiments where they have seen that this implant produces a good amount of obstruction, resulting in apoptosis and opening of the cavity, even extending up to 12 months post surgery. So patient selection, it's better to have a flexible cystoscopy so that you are aware of presence of the median lobe or intraprostatic extension or intravesical prostatic extension. There are various names by which the median lobe can be called. The intraprostatic extension, as long as it is less than 1 centimeter, it is doable with Urolift. So the best practice is to document the intravesical extension, IPS scoring, and quality of life. Say for example, this patient, there is a good documentation of the obstructing lateral lobes, and there is no much median lobe in this view. But once the patient had this J maneuver, we can appreciate the presence of the median lobe. This median lobe needs appropriate treatment, and since it is less than 1 centimeter from the bladder neck, we can perform a Urolift mid-lift technique. Now, this length has to be measured, and that needs to be appropriately documented. Lot of times a surgeon who is doing the urolift procedure may not be in a position to do this flexible cystoscopy, so the colleagues or the junior doctors or the referring doctors performing these procedures should document these things quite clearly. So urolift consists of 3 parts. This is the urethral end, which is made up of stainless steel. It's 8 millimeter in length, and we got a long suture which is made up of pit suture, just like the pit suture which you use in your open surgeries. And then we have the capsular tab, which is made up of nitinol. The total length of the capsular tab is 13 millimeter. These implants are MRI conditional, which means patient can have MRI. Only the small area of few millimeters where the implants are there, especially the nitinol tab, the MRI may not pick any peripheral zone lesions. But if the MRI sequence is appropriately tailored, there won't be any artifact due to the metal. And we have this implementation device which has got like 4 steps. The first step is releasing the safety lock. The second step is the blue switch. The third step is blue and gray switch at same time, and fourth one is the release of the implant. It's a very straightforward procedure which you can appreciate in this video. So as you can see, as a first step, we will unlock the safety lock, and then once we press the blue needle, you'll get the needle get nicely deployed, and then once you press the blue and gray, the needle get unsheathed and the implant is getting deployed into the prostate. And the fourth switch, the urethral release, will cut the suture and it will deploy the urolift into the patient's prostate. We can appreciate this by using some videos which I'm going to show. So our main aim is to deploy the urolift in the anterior 1/3 to create an anterior channel. There is no need to deploy in the middle or the lower 1/3 because of the neurovascular bundle. It creates a wonderful anterior channel which is more than enough for patient to pass urine. And we do the proximal implants first, just like TURP, because it will improve the water flow or irrigation flow, and then we'll do the distal implants, and if necessary we can do the middle zone implants. Sometimes patients may need 2 implants on one side and 3 on the other side, and sometimes there will be some extra nodules or the median lobe which needs median lobe separate implants. The main maneuvers which you need to be aware of is we need to make sure that the employer before deploying have this cystoscopic view of the white line, and everything is box standard deployment. This video will be very useful, and this picture shows the white line in the urolift implant. We need to make sure that the implant is appropriately positioned. That's the most important one. This video shows how the implant is done on the lateral lobe. The surgeon has come like 1.5 centimeter from the bladder neck, and he will give a compression maximum 20 degrees. There is no need to compress more than that. And then you can see that the safety lock is released, and then once the surgeon presses the blue switch here, you can see that the needle is deployed. It's a gray color needle, and then when he presses both blue and gray, the suture, you can see the blue one, and then he needs to move forward so that you can see the white line there in a second. You can appreciate now. And once you get the white line, you can release the fourth switch in the back that releases the implant, and then the surgeon can get inside the bladder and the implantation is complete. And I will show you the post view also. So Veru can be used as a landmark for the distal implants implantation, and here we are doing the distal implants where we need to come back, and bleeding is like an enemy for appropriate deployment, but with irrigation we can manage. Make sure that you are not too much away or far away outside. This patient had the proximal implant already done, so from the Veru, just make sure the Veru is disappearing in your eyes, and you are doing again the anterior 1/3 of the implant, again at 20-degree deflection or the angulation, and the safety lock, and blue and gray, and release. These steps will go just in 1 second. Even though I'm explaining it in detail, you can see even the white line nicely came, and that opens up the distal gland, and we need to repeat it on the opposite side also. Here you can see that the median lobe is getting treated. For median lobe, we need to again make sure that we are pressing the median lobe against one of the sides. As you know, the median lobe has got left and right groove. Select the groove which is more deep so that you can use that groove and use that as an option to nicely press the median lobe on one side. Initially, our hands will be high, and once the median lobe is in correct position, the hands will be appropriately lowered, and firing will be as same as the lateral lobes. The median lobe, if appropriately treated, those patients will have the best possible outcome. We know even in TURP, compared to patients with bilateral lobes, patients with trilobe or prostate or median lobe after TURP, because of the good deobstruction of the median lobe, they will be having the best outcome. Here you can see that the surgeon has nicely compressed the median lobe, and he is able to deploy it in the same anterior plane. No way we can deploy from the top because of the neurovascular bundle as we see in the radical prostatectomy. And once the hands are in the correct position with an angle maximum 20 degree, for median lobe maybe 10 degrees enough, we can deploy, and the release is by the needle in the back side. And you can see once it is deployed, the median lobe is nicely flattened and pinned against, for example in this patient, towards the right side of the surgeon. It opens up the median lobe cavity very nicely, and sometimes patients will need even the second implant based upon the individual anatomy, and I will show you the final result. There are some tissues closer to the sphincter, but once you get in, you can see the median lobe is nicely flattened and the lateral lobes also nicely opened up. This is the open prostatic cavity. You won't get the brilliant capsule to capsule cavity like TURP, but you will get a cavity which is more than enough for the patient to pass urine comfortably. It will make patients who are not fit for TURP eligible for a procedure. It will certainly help the patients to get away from the medications. So as you can see here, when you are keeping the implant straight, and if you fire, the implant will fire 12 millimeter in front of you. That's why we have to come from the bladder neck at least 1.5 centimeter back, so that the needle firing will not happen into the bladder neck. That's a precaution. And once you form the angle, you will get the appropriate implantation in the same line. And 40 degrees is too much, 20 degree is the ideal buy. And so you should be able to create the angle before proceeding the implantation. So here you can see that angle itself makes the urolift go up to the periprostatic one, so the capsular tab is appropriately deployed. If the angle is not there, the implant won't even reach the prostatic capsule. Similarly, if we are not 1.5 centimeter behind the bladder neck, the implant can be inappropriately deployed into the bladder neck. These are the things we need to avoid. This is the intraprostatic extension. We need to make sure that we are coming adequately behind to make sure that the implant is going only in the prostate. And regarding the anesthesia, this slide is the very old slide around 2014 when we had the lift protocol or lift study happening. They used diazepam, they used a catheter to place lignocaine into the bladder, but all these things seems to be unnecessary. Nowadays, my protocol is just the cold lignocaine, maybe 2 tubes 20 ml into the bladder, leave it for just 10 minutes. They can use like a gauze piece to tie the urethra so that it won't leak. If you have an access to the pinion clamp, it's not a bad choice. And then during the procedure, again use some cold lignocaine to get in so that you can create a good anesthesia. This is the usual setup. You need boxes of Urolift devices, you need a monitor, you need irrigation. We need a nurse dedicated to talk to the patient because I do under local anesthesia, so patients will be awake. So they need a person to talk to deviate their mind. This is the full system, which consists of 2.9 millimeter cystoscope set. It's a 0-degree cystoscope, so you are seeing everything end on, and there is a 20 French sheath, as I said, and we got the visual operator in case if you want to just do the inspection part of it. And we need some graspers in the unfortunate event where you need to remove an implant. So these are all the studies. We got the age-old lift study reaching now 8th year, and we have crossover studies and we have local studies which is on local anesthesia, which showed consistent improvement in 2 years and also at 1 year. And thank you very much. I will stop briefly here, and if there is any questions in Urolift related procedure selection, I can answer that before I go through the other energy sources. You are mute, Professor.
Am I audible?
Yeah, I can hear you now.
Yes, sir.
Yeah, thank you.
Okay, great. Thank you. So thank you very much. And that's a very nice demonstration of technique indication. And we have a few questions. So there's one question from Ahmed Bashir, and he wants to know if there is any bleeding during initial instrumentation. Is there any way of doing some form of coagulation or hemostasis so that your view is clear when you shoot the implants?
Yeah, that's a very important question. We need a very, very good vision. As I said, it is not just positioning, angling, and deployment. Before the deployment in the blue thread, we should be able to see that white line. The white line is the sign that the Urolift implant is absolutely 90 degrees and it is kept, the thread is PET suture is kept taut. Only if the PET suture is kept taut, once you release the urethral end piece and cut the thread, you will get a very good compression. So vision is very, very important. We are all quite sleek surgeons, especially after the endoscopic surgeries and laparoscopies and robotics. We have become very sleek, so there is no need for real coagulation separately unless if the patient had some bleeding veins, and if there is no good vision, you need to stop. You can take like a TURP, a rollerball, or you can use a Bugbee electrode to clear the bleeder. But in general, I never required to open any energy source before deployment. During deployment, sometimes if there is an obvious vessel in the mucosa, we will try to avoid the vessel. But sometimes there won't be any vessel in the mucosa, but once you deploy, you may have a gush of bleeding because there may be a vessel below or next to the capsule, etc. But once you finish the complete deployment, as I said, the urethral component and the capsular component will compress, and then that creates a good hemostasis. And stop placing catheters. If there is a minimal bleeding like the videos what I showed, there is no need for a catheter. Patient will be able to pass urine well. The chances of somebody having a significant clots requiring catheter or irrigation or overnight stay is extremely rare.
Okay. What about, because it is done in the local anesthetic, so I think a good choice for those who are not eligible for major regional or general anesthesia. And particularly in this age, there are a lot of people who are on anticoagulants.
Yeah.
So can you use this procedure for clopidogrel patient? Obviously, S-card is something which is not an issue, but what about those who are on clopidogrel?
Yeah, doing under local anesthesia, Professor, as you mentioned, it's a very big boon. I am getting referral from left, right, and center for patients who are not fit for anesthesia, not fit for even regional anesthesia. We presented kind of a semi-live surgery in World Congress of Endourology last year, where there was a Filipino patient with spinal kyphoscoliosis. So regional anesthesia is not possible. It's too short and short neck. So GA is not safe, and we have successfully done the whole urolift under local anesthesia. Regarding the anticoagulation policy like TURP or HOLEP or any surgeries, it is always advisable to stop the anticoagulants adequately. Say for example, clopidogrel means 5 days. If it is newer drugs like apixaban, rivaroxaban means like 48 hours, etc. But in the rare situation where the cardiologist felt that this patient had a metallic heart valve and can't stop the anticoagulants for maybe like 12 months, something like that, you can do the procedure. Especially I've done few under rivaroxaban, but you need to be a little bit more careful because a small scratch or a vessel can cause significant bleeding. Aspirin, no problem. 75 milligrams, 150 milligrams, aspirin is no issue at all. So if the patient is on any anticoagulations other than the antiplatelets aspirin, we will try to stop as normal. And in case if that patient is not fit for stopping, patient needs to be on anticoagulant, you can stop the medicine and start him on 150 milligram aspirin. Even if that is not enough, then we can give bridging heparin, a low molecular weight heparin. For example, if the patient is having the surgery in the morning list, he can have the last dose maybe like 10 o'clock or 12 o'clock the previous night. So after the procedure, patient can have clopidogrel, rivaroxaban, apixaban, any anticoagulant on the same day evening. We can restart, including warfarin, as long as the urine is staying clear.
Okay, there's another question by Shabir. He wants to know, it's a permanent implant. Can it be removed in any ways if it is for indicated inaccurate deployment or extrusion into the prostate or bladder? So can it be removed?
Yeah, it is a permanent implant, and if it is appropriately placed, as I said, if it is kept in the prostatic urethra, adequate compression and nicely placed, as you can see that the implant will get completely submerged in the mucosa. Especially if you do a flexible cystoscopy after maybe like even 1 month or 6 weeks, the whole mucosa will grow over the stainless steel urethral implant. You will see only the dimples in the prostatic urethra, and the cavity will be nicely opened up and nice cavity will be formed. But if the patient unfortunately had inappropriate placement, say for example the urethral tab is hanging in the bladder neck or unfortunately into the bladder, it has to be removed. Easiest way is by using a biopsy forceps or any like a two-prong forceps. There is no need for anything like a basket. And if the whole implant, the urethral tab and also the capsular tab, everything is there, the easiest way is just hold it and then you can pull it away because everything is inside. But if the easiest way is you can just take it into the bladder and then take it all together. But if the capsular tab is nicely implanted, the problem is only the urethral tab. As you can see, the urethral tab is just like a cloth peg which we use for the clothes. So the peg suture will be there, the cloth peg will be like this. So from your end, if you are able to hold the joint segment of the urethral tab and you need to pull towards you, it releases the suture so that the suture will get completely submerged into the prostate, which will not cause any problem, and you can remove the stainless steel urethral tab. So if it's only stainless steel urethral tab, hold the junction and pull towards you. If the whole implant is in the bladder neck, hold it and then push into the bladder so that you have enough cavity to go and then take the tab out outside. I've done easily 300 to 350 patients. I think I have removed the implant only once. And so, if appropriate precaution is taken, it is a very, very, very rare occurrence. The implants are costly, so it's better not to waste the implant also.
Great. I think you have demonstrated the technique, but still people are uncertain about median lobe. So Halimullah is asking that how would you know that your sutures are appropriately placed? If
Yeah.
the implant is appropriately placed.
Yeah, there are like major guidelines. Number one, the median lobe should not be more than 1 centimeter. If the median lobe is more than 1 centimeter protrusion into the bladder neck, it's not the correct procedure. We need to think about something like TURP, if not like holmium enucleation or any enucleation procedure. There is no doubt in that. And then the main aim is to, as I showed, we need to move the median lobe into the prostate and then select which part of the groove is more nicely and deep, and then if the left side is nice and deep, press the median lobe and then make the implants. And otherwise the implant, the firing and the safety of the white line, everything is just like a lateral lobe. Just how are you doing in the lateral lobe, the same thing you're going to do in the median lobe. The implants will go only in the horizontal plane wherever you are, and you can see that opening and the cavity straight away in your eyes. The easiest advice what I say is, you need to fire the implant as much into the prostatic urethra for safety. Even few millimeters inside the implant can become exposed to the bladder neck. So the only way you know that is, you need to remove the urolift device into the prostatic urethra by compressing the median lobe. At one point the median lobe will try to escape your urolift cystoscopy. At that point you know, okay, that is the break point. And then next time when you compress, you know that after 1 millimeter the median lobe is going to escape from your cystoscope. At that point you can deploy the implant. It's a advanced technique, but we surgeons always interested to have some challenge in the life, and that's why we progressed from open surgeries to laparoscopy to robotic, etc. So I will say, once you have done maybe 15 to 20 patients of simple lateral lobe urolifts, then you will be having a good muscle memory of firing and adequate control on the implant delivery system. Then you can start doing the median lobe. It is doable. The MedLift study is a very good example. MedLift study in fact showed that the improvement in the IPSS and quality of life is much better than the lift study, which got only the lateral lobe patients. The reason is, in median lobe you create much more deobstruction, so patient's outcome will be much better. So patient selection and technique, again the same two rules for urolift.
Okay, there are a couple of small other questions, but I think we can take them and we can move on to the next part of your talk. So kindly please proceed to the next level.
Okay. I will try to next discuss resume. I'm sure you will be seeing the slides in a minute. Okay, you can see the slides now. And thank you for my friends and colleagues who are working with me in producing the state of the art, good quality slides. I need to mention my colleagues' names in the slides. As you can see that the number of patients who are undergoing TURP is gradually dwindling way back in 2005 itself. So if we are able to have an update on this study up to 2013, you can see that the TURP will be much more into a very small share. And laser vaporization, transurethral needle ablation and transurethral microwave therapy, one of the past technologies, have taken over a share from the TURP. Resume is FDA approved in 2015. 2018 started in Europe and UK. There is now at least 2-3 randomized studies available comparing to sham treatment. Again, almost like Urolift, the follow-up is now reaching the 7th and 8th year. So this is the generator. We call it as the world's costliest kettle, because all it does is using a radio frequency energy to produce a high quality water vapor. And this water vapor is delivered by using this tip, the needle, and as the needle delivers the water vapor, the whole prostatic transition zone, which is the major zone for the BPH, got heated by the convective heat energy. And this is how the pre-op will be, including the median lobe, and post-op you can see that the median lobe and lateral lobes are nicely opened up. Even for resume, I will say you should restrict the median lobe to 1 centimeter, maybe up to 1.5 centimeter. More than that, it is not worth trying any of the minimally invasive treatments. So the whole boiling or convection happens at 100 degrees Celsius, where the energy is so high, and this energy is taken by the tissue, which results in ablation. And you can see that the temperature is the key point in creating the cell death and apoptosis. And resume works at 103 degrees, which is the perfect temperature for the convective energy to pass the energy into the prostatic tissue. As you can see here, the advantage of convective thermal energy is it spreads quite uniformly, it destroys only the cells, it preserves the skeleton, compared to the previous conductive energies like transurethral microwave therapy in the past, where it passes through the skeleton of the connective tissues and collagen, and it destroys everything on its way. So that's the main advantage of resume compared to the previous failed treatment modalities like transurethral needle ablation or transurethral microwave therapy. And here you can see that the median lobes are getting nicely ablated if the resume is appropriately placed. And this is the staining by TTC, which clearly shows that the median lobe is becoming avascular and ischemic. The beauty of this is the urethral mucosa is maintained. The convective energy source will not pass through the collagen, so the urethra is maintained without any ischemic changes, and peripheral zone capsule are maintained. So there is no reason that patient will get any collateral damage. And this is 1 week MRI, which shows the transition zone is getting shrunk, and even after 6 months you can see the transition zone is almost disappeared. And this 3D reconstruction again shows that there is a good decrease in the transition zone volume. And in this picture you can see how the resume is placed. So again you will have like a fixed equipment delivery system. This is a disposable delivery system. Patient should have a normal cystoscope, and then patient's anatomy and suitability need to be completely assessed. And here you can see that patient needs treatment on both left and right lobe. There is no need for a median lobe deployment. So again, deployment should avoid directly into the neurovascular bundle. It's better to stay just above it, and once you deploy, it automatically has a fixed time, and then the needle retracts after complete deployment. After that you can come behind, make sure you're not too far away from Veru or affecting the sphincter, and you can do the second deployment. Nowadays, there are some good evidences from Canada, from one of my good friend by name Dean Elterman. You may have met him during your SAU visit in Montreal. He has done some studies to show that there is no need to have like 4 or 5 times convective therapy on the left side and right side. A good 2 treatments or 3 treatments is more than enough. Similarly, this kind of treatments at 6 o'clock, now they are avoiding to prevent unnecessary injury to the rectum, and the lower part is left alone, which protects the neurovascular bundles. It's quite common that the treatment is done only in the upper half, almost similar to the Urolift. I will try to show some post-op images. And so this is the pre-resume. You can see that the lateral lobes are kissing against each other. Pre-op Qmax is 6 ml second with the post-void residue of 150 cc, and this is the post-op in 2 months time. You can see that the lateral lobes are nicely opened up and nicely flattened up. It's a good energy source, and appropriately if it is used, it will have a long-standing, it will stood the test of the time, I will say. Quite good for even the median lobe, and the anterior lobe is untreated, but you can treat the anterior lobe also, and verumontanum is preserved. And there are plenty of studies again, and because now we more depend upon the quality of studies, we got the studies comparing resume with sham treatment, resume with Urolift, resume with say TURP, and now we have got like a multi-arm studies comparing TURP with resume and Urolift and ITIN. There are various energy sources in study. Again, good improvement in IPSS, good improvement in quality of life score, and even the median lobe studies showed good improvement in IPSS and Qmax improvement. And the studies wise, they're all quite supportive. There is no doubt in that. There is no point in concentrating on studies, because what we need to concentrate is what is the energy source, is it doable, and what may be the economic implications in countries like Pakistan, which I'm not aware. When the energy source comes to your country, we need to see how it is affordable both from the doctor's point of view and from the patient's point of view. Yes, there will be some side effects just like any other cystoscopy or any other instrumentation, dysuria, hematuria, hematospermia, and urinary symptoms, but they are all quite reversible, and the patients will have good improvement in few weeks time. All patients who have resumed should have a catheter. So the reason is there is a temporary swelling of the lateral prostatic lobes, so the patient will have more obstruction temporarily. So patient should have a catheter at least on an average 5 days, and that helps the convective energy to resolve the lateral lobes and median lobes, and the catheter removal will be successful. This is one of the major like a disadvantage of resume. Patients who never had catheter in the past, they will feel very uncomfortable on those 5 days, where those who had catheter in the past, they will think, okay, another 5 more days and I will be free of the catheter. There is no evidence of any erectile dysfunction or ejaculatory dysfunction like Urolift. You can preserve the man potency as it is. The IEF score and sham scores are nicely maintained. And nowadays, instead of keeping the catheter, something like a marriage between a temporary prostatic stent, exime. I will discuss exime a little bit in detail once I finish the resume. So instead of the long catheter draining the urine, which is quite annoying the patient, we can place this temporary prostatic stent for the same 5 days. So water therapy accepted by AUA guidelines, EU guidelines. We have nice guidelines supporting it, and as you know, EU guidelines also, there is a good support on that. All the guidelines are quite equally working on supporting the minimally invasive treatment. So decision making is based upon the flow chart, which you all may know. It's a quite commonly quoted EAU guidelines present in 2022 volume also. And yeah, so resume is another minimally invasive treatment, and it's always nice to have 2-3 technologies so that you will get the best technology for the correct people. Good efficacy, low complications, higher chance for preservation of sexual energy, and this is another energy source definitely is going to stay for long term. Any questions on resume or any questions in comparison to Eurolift before we go to the last two energy sources, which are little bit small topics?
Right. Thank you very much. I don't see any questions, but what is the surrogate marker for success? I recently saw a patient who had resumed in Canada about 6 weeks back. We did uroflowmetry. His flow is quite poor, but symptomatically he is not too bad.
Okay.
So what would be the strategy at this point?
Yeah, I mean, I will strongly, quite heavily rely on how patient feels. End of the day, if the patient feels, doctor, my water works are fine, I can see the improvement compared to pre-resume or pre-Urolift, that is my main target to achieve. Sometimes the resume, as I said, it causes that prostatic swelling, which supposed to be temporary, only like 3 to 5 days time, but that swelling could be the reason why the Qmax is not good enough. But that Qmax may not be an actual reflection of patient's voiding in his home environment. So for the particular patient, if he feels satisfied with his urine stream and if he has no major side effects like erection or ejaculation problems, I will hold on, and maybe we can give a call maybe in another 3 months time. Here in UK, we are heading towards telephone follow-up, so we won't be able to do Qmax documentation, even though it's nice to have Qmax and IPSS score documentation for all the patients at 3-month follow-up. We do IPSS and quality of life scores over the telephone, but uroflowmetry we use very, very selectively. If patients, we call it as PROMs, patient related outcome measures. As long as the patient is comfortable, we can hold on. They will have quite long-term good outcome.
Okay. Thank you very much, Ananda. Please proceed with your next presentation.
Okay. So this is another evolving energy source. Maybe there is a good possibility most of you may not aware of this procedure. I will try to see this. Now you can see the slides. It is known as temporary implantable nitinol device, and previously in generation 1 it is known as TIND, and now the another biggest shareholder in the pharmacy industry, Olympus, has got the technology and they have renamed as iTind. And they have also made few changes, like for example they have improved the struts or the threads in the iTind, and it's almost like a second generation iTind, and it has a good value. It has stood the test of the time. Lot of articles and publications on pipeline, and so we have discussed the Eurolift, and this is the prostatic embolization, which I'm not going to discuss because this is more for a uroradiologist to present. But if somebody has any questions on prostatic artery embolization, I'm quite happy to answer. It's a very good technology. For example, very large prostate, 150 cc, 200 cc, patient presented with bleeding and not fit for big surgeries like enucleation. Those are the patients where prostatic artery embolization is quite good. We need a quite dedicated CT urogram so that we get the anatomy of the vasculature. Older men, sometimes the vasculature to prostate may be quite atherosclerotic, then your embolization won't adequately read the prostatic gland. If the vessels are good, if it is appropriately embolized, especially as long as we are doing a super selective embolization, prostate will lose its blood supply. As simple as that, just like embolizing bleeding vessel after PCNL, etc., and they will have really a good outcome. The side effects could be like any of the branches to the lower part of the bladder may get involved, and if it is inappropriately done, you can get ischemia of the trigone, ischemia of the lower ureter, requiring stenting, etc. But appropriate embolization will give definitely good result. We have discussed resume quite in detail, and now we are going to discuss the iTind. As you can see, iTind is a simple device. It's a temporary implantation. It works maybe for 5 to 7 days. After that, the implant is removed. So patient has the no fear of keeping an implant in the rest of the life. That's one of the main advantage of the iTind. So as I said, it's a second generation one. All the 3 prongs were now has got 2 filaments braided, and there is a tongue like another equipment which takes care of small median lobes or floor. In my view, iTind is very good for patients suffering from high bladder neck. Young patients, 40-year-old, 50-year-old, high bladder neck, but don't want to go for bladder neck incision, wishes to preserve the ejaculation, preserve the erection. iTind is a good device which creates nice 3 cuts at 12 o'clock, 5 o'clock and 7 o'clock. It's a temporary device. It's a bit of a pain those 5 days when the implant is kept in the place, but we have a good cocktail of like NSAIDs with some maybe steroids and painkillers, so that 5 days once passed, once it is removed, it gives a very good opening of the bladder neck. So any patients with pure bladder neck or maybe prostates up to 40 cc, iTind has a role to play. Once the prostate becomes more meaty, once it reaches 60 cc or more than that, we need to think about Eurolift, if not resume. And how it works, the iTind is placed on one strut at 12 o'clock, the other 2 at 5 and 7 o'clock with an anchoring leaflet. The anchoring leaflet helps in creating a kind of ablation of the median lobe if it is a small median lobe, and also it helps in immobilizing the implant. As you see here, the main work is done by the horizontal segment of the iTind. The slanting segment has not much role. So there is a good cuff of tissue preserved. So no way the opening is affecting the ejaculatory ducts or the sphincters. So sphincter, ejaculation, veru are completely protected. So this is how it will look inside the bladder before implantation. I will show them in the future slides. So you will get a 7 o'clock cut, 12 o'clock cut and 5 o'clock cut. Initially, maybe for 5 to 10 patients, you may need to use some short anesthesia like laryngeal mask anesthesia or sedation to keep the implant. But once you gain the technology, how to place it, you can do that under local anesthesia. So that's the main advantage of having the procedure. Patient can walk in, have the implant done, and then walk home. We can prevent anesthesia. So it can be completely done under local anesthesia. And doing under rigid cystoscope is the advisable one. We have got this nice guidelines in 2019. There is a recent edition in September 2022 which allows us to do the iTind placement in a controlled manner or in a supervised manner, which means you can't just like that do iTind for your patients and discharge them back to remote areas. You need to keep a tab on them, and you need to make a data, and you may have to publish it adequately. It's not something every unit can start. It has to be done maybe like a university centers or teaching hospitals. This is a good source to start. And they got a lot of studies like medical technology O1, O2, O6 studies which consistently showed that the IPS score Qmax were showing good amount of improvement. And they've got 3-year follow-up and 5-year follow-up. The medical technology O1 study was done with the first generation iTind, showing a good improvement of the IPS score and stable for almost like 3 years with good improvement of Qmax for 3 years. And the medical technology O2 study was done in the second generation device. As I said, it has got that extra tongue for the small median lobes. Again, they have got standard inclusion criteria, exclusion criteria, and these are all the endpoints which shows a good improvement of the IPS score and Qmax over almost like 3 years follow-up. So there is a good evidence to back the iTind also, and improvement in the post-void residue, improvement in the quality of life, and preservation of the sexual function. All the 3 devices, whatever I discussed today, it will not affect erection and ejaculation. That's the main beauty, and that's why they are in the market. And now we have the medical technology O6 study, which is a much more advanced study with a little bit of wider inclusion criteria, and we got the 6 months interim results showing again good improvement in the IPSS and quality of life. The one thing I want all the delegates to understand is none of these 3 will be equivalent to TURP. But if you think about TURP, patient definitely needs one or the other form of anesthesia, whether it's regional or GA. Patient requires appropriate resection, irrigation, definite one night stay, and even if you are doing a day care TURP, patient will go home with a catheter with removal maybe in a day or 2. But all other 3 resources what we have discussed, there is not much anesthesia, all are day unit procedures. Now we are trying to move all these procedures into outpatient clinics where patients will be having a flexi, then suitable they can go for Urolift just in a normal clinic environment. And so that's the main movement. So that releases the pressure in the theater. So I mean, these things may not be very appropriate for the countries like Pakistan, but releasing the theatre capacity, releasing the inpatient capacity is a very big ask as far as the NHS is concerned. And this is the medical technology O3 study which is now published. Again, the same good results. For exam purpose, if the trainees are able to say that iTind has got this medical technology O1, O2, O3, O6 studies which got appropriate improvement in IPSS, QOL and post-void, that's more than enough. I don't think anybody will ask the individual values. And these are all the publications for iTind and improvement in the IPSS and Qmax. And yes, the technology is here to stay, and but for very selective patients with prostate in the region of 40 cc or less than that, or patients with pure median lobe problems, or like small median lobe problems or bladder neck issues. So yeah, we can discuss any questions on iTind before we go for the last small presentation on temporary prostatic implants.
Yeah, I think there are a few questions about The question is about average, about how much time is required for an I-10 procedure approximately.
Yeah. In your early learning curve, you will be very precautious because you want to be sure, doubly sure on the placement. But if you think the procedure wise, all we are doing is we are passing the whole implant on, with cystoscopic working element or working channel, and once the element is deployed, we are making sure the three prongs are nicely placed 12 o'clock, 5 o'clock and 7 o'clock, and taking them into the prostatic cavity. Once we are happy, we are just removing the cystoscope. So once you are experienced, placement of this is just like placing a catheter. It should not take more than 5 minutes to 10 minutes time. And at any time, if the patient has difficulty in voiding after placement of the I-10, you can pass a 12 French silicone catheter by the side of the implant, and it can go into the bladder and drain the bladder also. As I said, this implant will be left for 5 to 7 days. That's where it opens up the cavity. That 5 to 7 days are a little bit crucial. Patient will have quite symptomatic storage symptoms, bleeding, etc.
Yeah, so this is one of the questions asked by Ahmed Junaid about the worsening of storage symptoms in the initial few days. So typically they last a week, 10
Yeah.
days, or longer.
It lasts as long as the I-10 is in place. So if you are keeping for, ideally, if you leave it for 7 days, longer it is left, maximum is 7 days, you will get a better cut. So if it is left for 7 days, patient will be symptomatic for 7 days. In our experience, some patients who can't tolerate, they will really beg to remove the I-10 even in 4th day or 5th day, and they also have a good adequate amount of opening. So if patient is comfortable, leave it for at least 7 days. If the patient is very symptomatic, you can remove it from 4th day onwards.
I'm sure that the patient may not be very comfortable, but is it any point in leaving a suprapubic catheter during this phase?
Yeah, these are our aim is to make it as much minimal as possible by placing a suprapubic. Yes, in one school we can think suprapubic is not a big surgery. Just put a suprapubic catheter and empty. It will take care of the drainage. Sometimes even we can place suprapubic just for the sake of safety. We can even place a spigot in it, ask the patient to void urine normally, and if he struggles, we can ask him to use suprapubic catheter. But the beauty is this I-10 won't cause any voiding problems. Patients passing urine will be absolutely good. In fact, with I-10 opening the prostatic urethra, if the patient is also passing urine, just like the same principles like a urethral stricture, where you open up the stricture and remove the catheter after 24 or 48 hours, if you allow the patient to pass urine, that stricture, whatever the internal urethrotomy you did, will stay open. And similarly, this I-10 work will be better if patient passes urine via naturalis. But the problem is the storage symptoms. Because of the tip of the I-10 irritating the bladder, he will have that persistent prostatitis-like feeling and storage symptoms of urgency and frequency and maybe nocturia. So patient will benefit from taking tamsulosin, sulfasalazine or mirabegron. There are some surgeons who use small dose of prednisolone steroids and NSAIDs like paracetamol, ibuprofen. So whatever the best possible cocktail for the patient to tide through that 5 to 7 days period. Once the patients are nicely motivated, they are quite happy to tolerate the procedure.
Thank you very much, Ananda. I think in the interest of time, we can move on to the last bit of your presentation. Okay. Please proceed. Thank you.
Thank you. This last one is more of like a completion, because this is not a procedure where you're going to have a permanent long-term solution, but this is a very niche technology, and I wish the trainees and practicing urologists from countries like Pakistan should know about this availability. So this is a temporary prostatic stent from the company known as Rocamed. It is known as Exime, and we have come across some implants or the prostatic stents in the past, like for example Memocath, even Allium came out with a smaller length for prostatic urethra, but none of them were really successful. The reason why they were not successful is all this Allium stent or Memocath stent, they are supposed to be left there continuously for long term, like maybe for years. So as I said, Anything if left for years together, exposed to urine continuously. See, in Eurolift, even though the stainless steel tab is there, it opens up and the whole thing get mucosalized. So there is epithelialized. So the mucosa will cover it. But in the stents like Memocath or Allium, they are still exposed to urine that causes storage symptoms, encrustation, stone formation, etc. So this Rocamed device of eczema is a kind of a marriage between all the minimally invasive things what we discussed and the temporary implant. Very good for patients who are waiting for TURP or HOLEP, where patient needs a catheter and you want to try this eczema stent temporarily. This also gives you an idea how good is patient's bladder function. So if a patient comes to A&E or emergency department, somebody places a catheter and lists for TURP, we don't know whether the bladder is still functioning, is there any hypocontractile element, etc. If these patients have Rocamed eczema temporary prostatic stent, then we know how good the bladder is functioning, so a patient can go for TURP or whole new enucleation as needed. As I mentioned briefly, after resume, instead of the long urethral catheter, they are trying to place the eczema so that patients won't be having the uncomfortableness of long catheter. Young patients, maybe some neurological problems, not really due to the prostate is the problem, but they need to be on a catheter for some reason. Eczema gives a wonderful opportunity because they still have some ability to have erection and ejaculation, and men can have penetrative sex with eczema in place. So it is a very good tool to maintain the quality of life for those unfortunate men. And it's a temporary prostatic stent, quite contrast to the previous three things what we have discussed. So the stent has got two main components. The prostatic part, it's an anti-kinking coiled tube, and there is a bulbar urethral part which is like a flat tube. We have made it flat so that it is more smooth for the prostatic urethra and bulbar urethra area, and these wings are known as anti-migration wings, so it prevents both distal migration and also proximal migration, and sphincter will be functioning, and that gives a good amount of continence. And there is a monofilament tether thread which will come out. And the whole set comes with two dilators, which is 22 and 24 French. So once you dilate the urethra, and then you can use the installation device. So once you place this installation device, during the dilatation itself, you know with the help of the graduation at what depth the bladder neck is and what depth the urine is starting draining. So you can pass this implanting device exactly to that measure, and once you release the screw and take out the bugey, the implant will get nicely placed, and the sphincter will also function so that patient will maintain the continence. And this video will be useful. So mainly the animation shows that the patient can be in the supine position, and we need to make sure that we are using the dilator. Even if the patient has no stricture, using this dilator which comes in the package will be quite useful, and makes the surgeon confident that before placing we are sure that the implant is going to work well. So the dilatation is only up to the sphincter. There is no need to dilate the prostatic part of it, and it will also give you an idea about at what height you are getting the bulbar urethra also. So this is the whole device. So again, patient's penis should be held taut, and then as you go inside, you know the length beyond which the holder should be holded, so that the whole thing goes in with the prostatic part of the stent alone going beyond the sphincter, and then release the lower lock so that the inner obturator will be removed. And once the inner obturator is removed, you can see that the implant is placed, and you can remove the outer sheath which is used for the rest of the penile. This thread can be nicely secured. We can cut it to the small level, and removal will be much more straightforward. All you need is you just have to pull by using the thread. Patient will be able to pass urine well. Initially, the patient will struggle a little bit because this place is now occupied by the two struts, but the patient will be able to, the implant also will slightly move to adjust with the prostatic sphincter. And removal is quite straightforward. All you need is a good grasping forceps, and the whole catheter, whole stent will come off. Good equipment for those who don't want to have catheter hanging on for longer time. No need for a leg bag. So if you compare the catheter cost, the installation devices cost, the balloon, syringe, leg bag, and everything, this may be a cost viable one. My main attraction or the advantage is you still maintain the bladder function. So bladder cycling is maintained, bladder is not getting drained continuously, and so in case the future patient goes for a definitive procedure for the prostate, you will have the bladder which is cycled, and the bladder volume is also nicely maintained. That is our main aim. And so it is good as a procedure for patients waiting for surgery, and those who are not fit for surgery, those who are left out for lifelong catheter, this may be a good option, so that it is quite cosmetically acceptable also. And the studies have done on acute retention, chronic retention, and retention prevention. Urodynamic test can be performed, and then it's quite good to evaluate the patient's striated muscle or sphincter function, diagnostic tool in neurogenic conditions, whether the bladder is working or not, and the ejaculation is maintained, and patients can have some erection and penetrative sex also. Again, there are some small studies to support that it is feasible. We have got some material like NICE guidelines which are supporting the use of it. This is just like a modified silicone catheter. It's made up of silicone, but instead of catheter coming out and staying for longer, we are able to make it more cosmetically into the required area alone. And it is now licensed to be kept for 3 months, so that's one advantage. Previously, 1 year back, we are supposed to change it every month. And local anesthesia jelly, calibration of the urethra, the steps are very straightforward. And again, I think this technology has a very selective role. Patients don't want catheter, don't want leg bag, want to have the bladder cycling, those who are waiting for the procedure, and also for the patients who had resumed, where instead of catheter we can keep this exime to tidy up that initial 1 week period. And the whole set comes in a very compact package, including the dilators. So yeah, again, I don't know how long it will take for these technologies to reach Pakistan, but it's at least nice to know that there are some temporary stents available. We don't have to depend on the age-old Memocath and the older technologies also.
Thank you very much. And I think the beautiful demonstration of some of the newer things which are available in the market, and there is good quality evidence available for most of these things now, including the guideline recommendations. There are a couple of questions that are there, which, so for one question is by Dr. Nazam about the incidence of bladder neck contracture in patients who have resumed.
Again, it's quite rare, and there is no reason why somebody should have a bladder neck contracture. Like I explained, none of the sources should be applied quite close to the bladder neck. So we need to give at least like 1.5, if not at least 1 centimeter from the bladder neck. That's what the literature says. And the expansion of the convective energy bubble is only to 1 centimeter. So in essence, the heat energy, the convective energy should not reach the bladder neck. You will be distal to the bladder neck. If at all, if there is any problems like bladder neck contracture happens, it's only because inadvertently the surgeon is quite close to the bladder neck during the implantation of the resumes energy in the initial areas. So as long as we are 1 centimeter away from the bladder neck, these things are anatomically or at least physiologically impossible.
There's a question by Professor Nasser Orakzai about how do you make a decision? You're doing both procedures, I mean, Urolift and Resume, and obviously iTend as well. But how do you make a decision between Urolift and Resume
Yeah.
in a patient?
Yeah, it's a fantastic question, because this is one thing If I answer supporting one of the energy, people can call me that I'm quite biased. The easiest thing is we have got information leaflet on Urolift resume I-10 from British Association of Urological Surgeons, and we have got nice guidelines also. Slowly we are trying to incorporate urology nurses into our one-stop male LUTS clinics so that the nurses will be able to counsel the patient just exactly like how I'm going to explain now. Patients should know exactly what they are signing up of. There is no doubt that evidence wise, whether Eurolifts, BPH 6 study, lift study, mid lift study, and resume wise, like sham treatment study, randomized study, the studies wise, no doubt they are quite comparable. The outcome is quite good. In Eurolift, patients should know few things like it's a procedure can be done completely under local anesthesia, while resume doing fully under local anesthesia is a bit challenging. At least patient needs a touch of sedation, if not a quick laryngeal mask anesthesia, because when you inject the steam, it goes for 9 seconds. The last 3-4 seconds patient will feel the bulge, so patient should be suitable for some short very quick anesthesia, while Urolift is suitable for patients who are completely unfit for any form of anesthesia or sedation. And then in Urolift, patients should get convinced that they are going to have the implant for rest of their life. It's not a big thing, but for some men who are a bit body conscious, they may find it's bit no. In resume, they should understand that it's a type of a heat energy and they should understand the consequences. Post-operative, especially the immediate post-operative wise, Urolift is a very smooth breeze. There is no major problems. Patient can walk home or drive home, and minimal hematuria or dysuria is quite manageable. There is no need for any specific regimens. But resume, they need a catheter. That sometime may be a big downside for resume, so they should accept for a catheter at least for 3 to 5 days. By any chance, if the catheter falls off in a day or two and if patient goes for retention, it is impossible to keep the catheter when patient is awake. Patient needs to be anesthetized, and we need to place the catheter appropriately. So resume patients should have a good catheter for 3 to 5 days. So those who already got a catheter, they may say yes to resume. Those who never had a catheter, they may be more leaning towards Urolift so that they don't have to have the catheter either before or after the surgeries. So, but evidence wise, long term outcome wise, both almost score equally. And also it's individual. So if you are trained towards one of the technology, and if you are good in one of the technology, there is nothing wrong in leaning towards that also. So if you have like a multi consultant multi department practice, it's always nice to have one consultant doing resume and getting proficient in it, and one consultant doing Urolift, so that we can give quality service to men on both the technologies.
Thank you very much. One last question. I'm sorry we have exceeded our time. Mr. Ahmed Junaid is asking about retrograde ejaculation with eczema in place.
Yeah. Regarding retrograde ejaculation, the whole anatomy and concepts are changing, especially in 2022 now. So previously, if you say this is the bladder, as long as the bladder neck is opened up, patient will get retrograde ejaculation, either by TURP or bladder neck. That was the concept. But now the concept is changed. The ejaculation is predominantly due to preservation of Veru, preservation of the ejaculatory duct, and preservation of tissue around the Veru. So any energy source, whether it's Urolift or resume or I-10, as long as they are not working around the Veru, the ejaculation will be maintained. Regarding the eczema, again it will short stop of the sphincter, and so the ejaculation will be still maintained. It won't be brilliant, and maybe during the ejaculatory episode patient may feel that the catheter is giving a kind of a pressure during the ejaculation period, but erection and ejaculation is possible. Penetrative sex is possible to certain extent, so those kind of quality measures are definitely maintained with this eczema temporary stent.
Thank you very much. And again, I apologize for extending beyond our time of 1 hour.
No
I
worries,
think
no worries.
people were really excited by all the technologies that you've talked about this evening. And I think they must have got a very fair idea about hopefully we'll have you next year sometime in our annual conference.
Sure.
You may be able to run a workshop and show them in how to do these things. So thank you again, and a very good weekend and a very good evening to you and to the rest of our group. So hopefully see you again soon.
Thank you,
Take
Professor
care.
Akhtar. Thank you for the opportunity. Thank you for your team, including Sharaf and others. And it's my pleasure to talk on this technology. I'm very sure next year, if you're calling me for the same type of webinar, there will be two more extra technologies which we may be able to discuss. We are running a workshop covering all these technologies quite regularly in our British Association of Urological Surgeons annual meeting happening every June. And I will take this opportunity to invite anybody attending the meeting to join us in Birmingham. And we are able to do this workshop even in the Society of International Urology. Recently happened in Montreal, and next year it will be in Istanbul. Once you attend these workshops, you will get a hands-on simulator-based training on all the technologies what we discussed. That will give you a much more clarity on the mechanism of this technology. I'm very sure when if you are able to invite me for the next annual conference, we will try to mobilize the simulators and do a good workshop so that the trainees and delegates are getting a hands-on experience. I'll be looking forward
Great.
for it.
Looking forward to that. And thank you very much and take care.
Thank you
Good
very much.
evening.
Have a nice weekend, everyone.
You too.